So for our second speaker for today, Dr. Monzr Almalki, it's a pleasure to actually introduce him to all of you. So he's an associate professor at the Department of Hematology and Hematopoietic Stem Cell Transplantation at the City of Hope. He's also the director of unrelated and haploidentical and cord blood transplantation. He will be taking us today through his expert eyes to tell us what would be the best way of choosing donors who are only candidate for match unrelated transplant, and how this choice could prevent complications, especially graft versus host disease. Dr. Almalki, the mic is yours.
First, I would like to thank the leadership in King Faisal and the organizing committee and the moderator for this kind invite. It's my first time in Riyadh. It's a really nice city. Thank you again, and this is my disclosure. None of this is relevant to what we are going to discuss today. The objective of this talk will be to shed the light on the importance of alternative donor transplant in the current era, look into the historical outcome of mismatch unrelated donor, and try fast in 20 minutes to talk about how to optimize the platform of this donor with some future direction. Allogenic transplant, as we all know, is proven curative therapy for many hematological and non-hematological disease. HLA, transplant from HLA matched sibling donor is still considered the standard of care. Both minor and major histocompatibility antigens are matched, so you're expecting to have the best outcome using that type of donor. The chances of having matched sibling donor in the United States is in the range of 20 to 30%, but I've seen recently a paper from Middle East, and it looks like it's up to 50 to 60% in our population here. And this slide shows the increase in number in transplant in the United States over time, and mostly due to improving donor availability, with different registry trying to recruit more donor, advances in the treatment and the conditioning regimens, as well as GvHD prophylaxis, etc. But as we can see from those curves, and it's in the green and orange, two donors have been increasingly been used in the recent decade. And we can see how MUD is increasing, mostly with the increasing number of mismatch unrelated donor, as well as the haploidentical donor transplant. In this graph here, you can see the likelihood of finding 8 out of 8 match unrelated donor. In this old paper now, it's more than 10 years ago. And you can appreciate here that patients of minority ancestry have low chances of finding match unrelated donor. Example for here in Middle East and North Africa ancestry, the possibility of finding donor in this slide shows 40 to 50% only. After doing confirmatory typing, workup, and medical clearance, all those issues that we deal with on daily basis on those donors. And in this paper, it shows that the number significantly drop, and the final clear donor could be difficult to find. For example, in white here, it went down from 75% on the preliminary search down to 50%, and we would expect in Middle East 40 to 50% to drop to 20 to 30% only. So really small chances to find that, and there is unmet need to find more alternative donors. And this is where those choices come into play. And as you can see, we're going to focus today on the mismatch unrelated donor for the sake of this talk. And this is quickly just one of the first papers to confirm the importance of HLA typing, predicting outcome of transplant with unrelated donor. This is a smaller type of old studies, included mostly leukemia patients. 100% of patients were with bone marrow graft and 100% received myeloablative regimen. So really the old way of doing transplant. Long-term follow-up though, and we can see that clearly there is an increase in risk of GvHD associated with more mismatches in the donor. This leads to lower survival in this population. Later on in 2014, Joe from Moffitt did this study which included 8,000 patients, a little larger and more contemporaneous type of population, included some pediatrics, peripheral blood stem cell grafts, and some other diseases, and then mostly was done with a conventional GvHD prophylaxis platform. Here we can see similar outcome. The message is the same. Mismatch cause more GvHD and less effect on disease relapse. On subset analysis, they did multivariable analysis, and they found that outcome did not get better when a different GvHD platform was used, and the ones that are included in this paper was methotrexate-based, ATG-based, and MMF-based. Again, the outcomes shows worsening survival with more mismatches, and as you can see, even the patients with advanced stage where transplant is needed right away is still not showing improvement with the mismatches. Both allele and antigen, this table shows that regardless of this, mismatch, there's some. I hear that allele is better than antigen, antigen is worse than allele, but this seems like not true based on the data that we have, and any mismatch is mismatch, and any mismatch can cause more GvHD for patients. So in summary, mismatch unrelated donor outcome is worse than MMUD. The outcome is worse when higher number of mismatch is found. Allele mismatch is as bad as antigen mismatch. And all 8 loci mismatch are the same. DP and DQ are additional. This stands correct in the setting of any conditioning regimen, and this stands correct in the setting of conventional GvHD prophylaxis, and this stands correct regardless of the disease type or the disease stage at the time of transplant. At the end, donor age, gender, ABO, CMV, pregnancy history, and DSA, all of those will play a role on top of HLA. Moving on to the novel approaches in improving outcome of mismatch unrelated donor, multiple groups have been trying in different type of new platforms to try to improve upon the finding that I just showed. And as we can see here, we have multiple different approaches. And then I'm going to touch on each one of those really quick. In this study, we analyzed outcome of patient undergoing mismatch unrelated donor with sirolimus-based therapy, all in reference to fully matched donor. 500 patients from single center from City of Hope with peripheral blood stem cell transplant. Half of them received reduced intensity and half much myeloablative. Most of those mismatch-related donors received tacrolimus, sirolimus, plus either mini-methotrexate or ATG, based on the study that was open at that time. Even though this platform is able to improve, as you can see in the beginning of the curve, the incidence of acute graft-versus-host disease and affect the short-term non-relapse mortality, but the impact on survival overall was not really great, and we still see those 10% decrease in survival at the end in our study due to chronic graft-versus-host disease complications. And this was true, regardless of adding the third, as you can see in the top table, adding third agent, mini-methotrexate or ATG, did the same thing, although some of those p-values are not significant due to small samples when we get to subgroup analysis. Also, overall survival was worse, regardless of the mismatch loci. As you can see, significant worsening in outcome in all of them. B here did not have significant p-value, but that was due to the fact that we try to avoid DR mismatch in my center, and we don't have enough cases of that. Later, the group in Seattle published this prospective study with 76 patients, small study, but for mismatch-related donor, consider decent. All of the patients received the Seattle regimen with non-myeloablative treatment, fludarabine and TBI, 2 grays, then they increased it to 3 grays, and they included all mismatched donor. Here in this study, for some reason, they had 8% of related donor that are mismatched, but those probably are noise background and probably shouldn't have included in the study. But patient with malignant hematological disease who received this type of transplant receive afterwards cyclosporin and sirolimus, and they added here MMF instead of minimethotrexate or ATG the way that we do it. And as you can see here, again, there is a significant impact with the triplet on the acute graft versus host disease in the beginning of the curve. As you can see, the grade 3-4 is flat, but then when you look at the chronic graft versus host disease and long-term outcome, you start to see dropping in the curve. Another novel approach was to use abatacepts, adding to the tacrolimus methotrexate platform, and then, sorry. In this cartoon, we show the basics ABC presentation of antigen and activation of T cells. And as you know, ABA is a CTLA4 antibody that blocks the co-stimulation signal between CD80 and CD28, leading to inhibition of T cell proliferation, leading to a decrease in the function, and hopefully a decrease in GvHD. ABA1 came initially, and they did look into myeloablative transplants using TAC methotrexate with 4 doses of abatacepts, and the dose here usually is 10 milligram per kilogram for patient. And they delivered that on day 1, 5, 14, 28, and they established feasibility, encouraging low rates of GvHD, and based on this curve, we can see that with the 4 doses of abatacepts and the pharmacokinetics that is included, we are able to cover the first 50 days of transplant and decrease acute graft versus host disease. After this, ABA2 came, and the primary objective for that study was to determine the impact of abatacepts and the incidence of early severe acute graft versus host disease when it's added to this regimen. They had two different cohorts, 8 out of 8, which was randomized to receive ABA versus no ABA, and then 7 out of 8 unrelated donor cohort, where they just compare it to CIBMTR. And when we focus on the MMUD cohort, we find that most of the patients with pediatrics, since this was initiated with our pediatric colleagues, most of them getting myeloablative regimen, half of them getting bone marrow graft, and the comparison was done with the CIBMTR. The sample size was small, so this is a good first step to show that this regimen is valid in this type of setting, but yet not very applicable to the population that we see on a daily basis. Here they compared the TAC methotrexate with no ATG in a CIBMTR cohort, and they consider, and as we all know, that having only TAC methotrexate for mismatch-related donor, and based on all the data that I showed earlier, is not optimal therapy, but this is what the comparison was like, and we see less acute graft versus host disease as we expecting, again, only in the beginning, as you can tell, with the same concept of 4 doses that we talked about, and then subsequently, and due to this outcome, they initiated ABA3, where they're randomizing now 4 doses to 8 doses, thinking that they might be getting some chronic graft versus host disease effect if we increase the doses into this population. Then they compared, also ABA with a CIBMTR cohort, now using TAC methotrexate with ATG, since ATG has been used for match unrelated donor before, and they had good case control, and they found that the acute graft-versus-host disease is still lower, as we discussed before, but again, with no effect on chronic graft-versus-host disease and competing with ATG was tough, so the end point at the end with the survival was not seen, and it was negative comparison. And then this is another approach using post-transplant cyclophosphamide. As we all know, more data coming with the post-transplant cyclophosphamide rule on GvHD to prevent graft-versus-host disease, first in haplo and then in matched donor setting. But 2 studies were done concurrently. This is the first one with NMDP sponsored multi-center using bone marrow graft. And 2 different cohorts, but again, as you could just point out in this population, the 2 main issues here is using bone marrow graft and using 40% of patients using less than 7 out of 8 matching donors. This shows a good outcome at 72% at 1-year survival, and was not different between MAC and REC. Relapses were promising, and non-relapse mortality was kept below 10%, which is very promising for this approach. The second study was a single study that we did in City of Hope, and the main difference here is that this study was included peripheral blood stem cell graft. We did the same with 2 cohorts, myeloablative and reduced intensity, and we had used the same regimen that we use for haplo. 50% of those patients had comorbidity index of 3 or more, and 1/3 of those were high to very high DRI. So very sick population in this. In our study, we did not limit the age of the donor, so we were able to find mismatched donor at 7 out of 8 for mostly 95% of the patient in this study. Again, when you lower the age cutoff for your donor, your matching ability will go down, and that's why the NMDP study was included 40% of patients who had 6 out of 8 and 5 out of 8 even. Those outcomes look the same. Again, very good overall survival at 1 year. Here in our study was 87%. No graft failure. Time to engraftment is similar to what we see with post-transplant cyclophosphamide platform at 16 to 17 days. And, we did some kind of immune reconstitution data here, and then we showed in the paper that your reduced intensity transplant were a little bit tough, maybe probably due to use of milfinane, and we see some decrease in lymphocyte recovery early on, but by day 180 and on, everything became similar. Also, we looked at infections, and as we know with this platform, grade 2 infections are increased, and we saw the same thing in our data. We also looked at CRS, since CRS is an issue with this platform using peripheral blood more than bone marrow, and we found that 70% of our patients in this study had some form of CRS, mostly grade 1 and 2, and we did not see grade 3 and 4 like we see in haplo transplants. Those 2 studies led to a multi-center study access, and we presented in ASCO this last summer the preliminary stratum 2 for only reduced intensity. We had 70 patients in the REC arm. Median age was 65. Again, you see this over and over. More patients of minority ancestry are included in those studies, telling you that this type of approach is addressing unmet need for those patients. Majority received cryopreserved. We conducted the study during COVID, and everything was cryopreserved at that time. And donor age was low because NMDP always want younger donors. And the study was positive, similar to what we just showed. with excellent grafts, non-relapse mortality of only 13% in a multi-center type of approach, which is great, relapse rate close to 20%, and severe chronic graft-versus-host. And this is where POSI is impacting all those outcomes by decreasing the severity of chronic graft-versus-host disease. It's only 9% in this study after completing almost 13, 14 months of follow-up. When we looked back and compared that to CTN 1703, as you know, this study was using post-transplant cyclophosphamide in a matched donor. We show similar type of study. We did publish this CIB-MTR analysis that was looking at all close to 10,000 unrelated donor, and we show the same finding in the registry. When you use POSI, 8 out of 8 and 7 out of 8 is the same. And I'm going to go fast here. This group from Miami and Memorial both together published a study to compare ATG to POSI, and they showed in this retrospective small study that POSI is better. Details are in this paper. I'm sorry because I'm running out of time. And we did look at the triplet sirolimus-based versus POSI. Also the same thing, close to 400 patient, large study, retrospective, very homogeneous. 40% receiving radiation-based and 8% receiving Flumel-based, and we found out that there is a significant improvement in overall survival for those mismatched unrelated donor when you use post-transplant cyclophosphamide. This is the last one, and this is an abstract presented long time ago, but I have not seen a publication yet for it. This was done by Dr. Keen and was sent to ASH before in 2021, I think. Again, comparing post-transplant cyclophosphamide to abatacept, there is no mention of long-term survival. As you can see, they truncated at 6 months. There is no difference at 6 months, but I'm expecting when we look at long-term survival, you will see that chronic GvHD is going to be an issue. I apologize for going a little bit longer, and thank you for listening.